Good evening, everyone. I'm Santhosh Padala from Virginia Commonwealth University. First of all, I would like to thank Dr. Karthikeyan for the kind invitation. My topic is conduction system pacing, current evidence and indications. These are my disclosures. Keeping today's audience in mind, I'm not going to delve into the technical aspects of conduction system pacing, but would rather present evidence against RV apical pacing and evidence for conduction system pacing. It is now very well established that our chronic RV apical pacing causes cardiomyopathy. This is our David trial published in JAMA in 2002, showing that patients who were randomized to DDDR pacing at 70 beats per minute had higher composite endpoint of death or heart failure hospitalization when compared to patients who were randomized to VVI backup pacing at 40 beats per minute. Another landmark trial was the most study published in 2003. In this study, patients who required RV pacing more than 40% had higher incidence of heart failure and atrial fibrillation. Recent studies have, however, shown that pacing burden more than 20% is enough to cause pacing-induced cardiomyopathy. So how long does it take for somebody to develop pacing-induced cardiomyopathy? This is a large national database study by Dr. Suneet Mittal's group. What they found was the risk of pacing-induced cardiomyopathy is highest during the first 6 months post-implant in patients with complete heart block. In chronic phase, which is more than 6 months after pacemaker implantation, the risk of pacing-induced cardiomyopathy remains. However, it's attenuated when compared with the acute phase, as seen by the hazard ratios here. During the acute phase, it was 1.62 versus 1.16 during the chronic phase. So the bottom line is chronic RV apical pacing results in interventricular and intraventricular dysynchrony, leading to increased risk of heart failure hospitalizations, increased risk of atrial fibrillation, and increased risk of mortality. So what do the guidelines suggest? The 2018 ACC-AHA guidelines recommend that in patients with AV block with an EF of 36% to 50% who are anticipated to require more than 40% pacing, it is reasonable to consider physiologic pacing. That is cardiac resynchronization therapy or His-Bundle pacing over right ventricular pacing. They give it a class 2A recommendation, whereas in patients with AV block with normal EF, they give a class 2B recommendation for His-Bundle pacing. So let's talk about conduction system pacing. So first described by Dr. Desmukh et al. In 2000. However, it was not until 2015 when His-Bundle pacing gained significant momentum. This study was published by Dr. Sharma and Dr. Vijayaraman and showed that His-Bundle pacing success rates were pretty high at 80% without the use of a backup catheter, backup mapping catheter, or a backup lead. So how does conduction system pacing preserve electrical and mechanical synchrony? This is a nice image showing conduction down all the fascicles, resulting in narrow QRS. However, when patients have right bundle branch block or left bundle branch block, it turns out that majority of the cases, the block is at the level of proximal His. So in this patient with the left bundle branch block, the block is at the intra-Hisian left bundle branch area. This is a concept of longitudinal dissociation, where the fibers which are predestined to become left bundle branches are blocked in the proximal His area. So when we are doing His bundle or left bundle branch pacing lead implantation, if we can get distal to the side of block and pace, we will be able to recruit the bundle branch blocks. So resulting in normalization of QRS. The other theory is the virtual electrode effect, wherein if you have diffuse disease in the proximal His bundle, or if you're pacing proximal to the side of the block and increase the output, you can capture the fibers distal to the block, resulting in recruitment of the bundle branches and normalization of QRS. So these are the two common mechanisms by which conduction system pacing can maintain interventricular and intraventricular synchrony. So since 2015, there have been several studies on His-Bundle pacing, primarily from the experienced centers reporting success rates of about 90 to 95%. This is an important observational study published by Dr. Vijayaraman in the JACC, which proved superiority of His-Bundle pacing over RV apical pacing. The primary outcome of death, heart failure hospitalization, or upgrade to biventricular pacing was significantly lower in patients who received His-Bundle pacing compared to RV apical pacing. This difference was observed primarily in patients with ventricular pacing burden more than 20%. So how about success rates of His-Bundle pacing in patients with AV block who are anticipated to require high pacing burden? This study showed that in patients with AV block, the overall success rates were about 84%. When they divided the patients into AV nodal versus infranodal block, the success rates were significantly lower in patients with infranodal block at 76% when compared to 93% in patients with AV nodal block. So how about success rates from an experienced EP group implementing His-Bundle pacing for the first time? In this study, the overall success rate was about 75%. However, when they compared success rates in patients with narrow QRS versus patients with bundle branch block, the success rates were significantly lower at 65% if they have wider QRS at baseline compared to narrow QRS at baseline. Furthermore, the type of AV block also influenced success rates. In patients with Morbid's type 1 AV block, the success rates were 92%, 81% in patients with Morbid's type 2 block, and the lowest success rates were noted in patients with complete heart block at only 56%. So how does His-Bundle pacing perform for resynchronization therapy? So this is a nice study by Dr. Zachary Winner's group. On the left side, you can see the scale showing red is early onset, whereas blue and purple indicate late activation. So these are the isochronal maps. Panel A represents patient with intrinsic left bundle branch block. You can see the earliest site of activation is on the septum, RV, and then the latest activation is the LV lateral wall. When we do bi-V pacing in these patients, you can see two wavefronts, one from the RV apex, one from the basal lateral LV, two non-physiologic wavefronts activating the ventricles. When we do His-Bundle pacing, and if that results in complete left bundle branch correction, you can see the earliest site is at the septum and rapid activation of the RV and the LV. This was a small study, 20 patients, head-to-head trial, acute crossover comparison design. And what they found was that His-Bundle pacing was associated with more effective ventricular resynchronization than biventricular pacing. His-Bundle pacing resulted in greater reduction in QRS duration, greater reduction in LV activation times, and greater reduction in LV dysynchrony index. His-Bundle pacing also produced a greater acute hemodynamic response in that there was an improvement, significantly higher improvement in systolic blood pressure with His-Bundle pacing compared to biventricular pacing. Since then, there have been several papers on His-Bundle pacing. This was a paper showing that His-Bundle pacing is very effective in patients with pacing-induced cardiomyopathy. There have been papers on His-Bundle pacing for cardiac resynchronization therapy in patients with heart failure and right bundle branch block, in patients with heart failure and left bundle branch block for resynchronization. And then there was the first randomized study, the HIS-SYNC study published in JACC. This was a small study comparing His-Bundle pacing to biventricular pacing. The main limitation was that there was a very high percentage of crossover in the study. These studies beget an important question: is His-Bundle pacing the holy grail of pacing? So how does His-Bundle pacing perform long-term? So this is a retrospective study published in JCE in 2019 from two experienced centers. This study included 844 patients who received His-Bundle pacing leads between 2004 and 2016. The mean pacing capture threshold at implant was 1.6 volts, and at chronic follow-up was 2 volts. The mean R waves were 5.8 volts, 8 millivolts at implant versus 6.1 millivolts at chronic follow-up. During a median follow-up of 3 years, Hispanal pacing was free of any complications in 91% of the patients. The authors concluded that Hispanal pacing was safe and effective during long-term follow-up. However, on careful review, pacing thresholds more than 2.5 volts at 1 milliseconds were noted in about 1/3 of the patients. Septal pacing on ECG at follow-up was noted in 9% of the patients. Lead deactivation rate was 7.6%, primarily for high thresholds. Median battery longevity was only 5.8 years. And this is our experience, intermediate term performance of Hispanal pacing leads, recently published in Heart Rhythm. We looked at 295 patients who received Hispanal pacing leads. Mean follow-up duration was 23 months. Hispanal pacing was successful in 93% of the patients. 33% had selective Hispanal pacing and 67 had non-selective Hispanal pacing. And during a mean follow-up of 23 months, these are the lead parameters. As you can see, the mean threshold increased significantly from 1.1 to 1.7 volts at mean of 0.8 milliseconds pulse width. Similar to prior paper, about 24% of the patients had high thresholds, that is more than 2.5 volts during the follow-up period. And 17% of the patients had loss of Hispanal capture, and 11% of the patients required lead revision during this chronic follow-up period. These results are concerning. So these are the potential drawbacks of Hispanal pacing. It can be technically challenging, and the success rates vary significantly based on the underlying presence of conduction system disease, underlying bundle branch block, and cardiomyopathy. R waves can be small, leading to oversensing or undersensing issues. But the most important issue are the thresholds. Usually, Hispanal pacing leads have higher capture thresholds at implant, and there is delayed, unpredictable rise in Hispanal capture thresholds, which can lead to exit block. High threshold translates to attenuated battery longevity, frequent device replacements, and possible device infections. While there were ongoing efforts to overcome these issues with Hispanal pacing leads, such as improving lead design or delivery sheets, Dr. Wang from China published this game-changing case report. In this case report, they report a 72-year-old female with dilated non-ischemic cardiomyopathy with left bundle branch block. In that case, they were not able to implant a CS lead or Hispanal pacing lead, so they went distal to the Hispanal branch and deeper in the septum to capture the left bundle branch. So by doing that, when you capture the left bundle branch, you typically get a right bundle branch QRS duration. So this is the QR pattern we typically see, or RSR prime pattern. So in this case, with left bundle branch pacing, within few months, EF completely normalized and heart failure symptoms resolve. One of the advantages with left bundle branch pacing is, in addition to getting a narrow QRS duration, you can also optimize the AV delays. For example, in this case, you can see if at the AV delay of 30 milliseconds, if you are pacing the left bundle branch, you get a QR pattern. But as you adjust the AV delays from 30 to 40 to 60 to 90 milliseconds, you can see you can completely normalize the QRS. This is because as you adjust the AV delays, you can allow the intrinsic conduction to come down the right bundle and activate the right ventricle, and during the same time pace the left bundle and activate the left ventricle. So now you're simultaneously activating the right and the left ventricle, resulting in complete normalization of the QRS. So since the initial case report, there have been several publications on left bundle branch pacing. There have been feasibility studies. There have been studies specifically looking at AV block patients. There have been non-randomized studies for cardiac resynchronization therapy, and also patients post-TAVR. This is our viewpoint published in Heart Rhythm O2, and we believe that left middle branch area pacing is the best approach to physiologic pacing. This is because of our experience. This is our initial experience published in JACC last year. This was a multi-center study conducted at VCU and at South Lake Regional Heart Center in Canada. We attempted left middle branch area pacing in 341 patients and were successful in 89% of the patients. We had high success rates in patients with underlying bundle branch block and patients with AV block. These were the indications. As you can see, 28% of the patients had sick sinus syndrome, and about 72% of patients had anticipated high RV pacing burden. This is a table showing procedural characteristics. As you can see, the baseline QRS duration in patients with infrahisian disease mean was 144 milliseconds, and with pacing, it significantly reduced to 115 milliseconds. And importantly, during a mean follow-up duration of 126 days, the thresholds and R waves remain stable. How about left middle branch pacing for cardiac resynchronization therapy? This is an important study published by Dr. Wong. In this study, they included 63 patients with non-ischemic cardiomyopathy and underlying left middle branch block. They reported a pretty high success rates of 97%. As you can see, if you look carefully, the mean baseline QRS duration was 168 milliseconds. Mean paced QRS duration with left middle branch pacing was significantly lower at 117 milliseconds. And when they optimized the AV delays, it further reduced to mean of 103 milliseconds. Importantly, the thresholds at 12 months remain low and stable. This was the echocardiographic data. At 1 year, you can see the mean EF improved from 33 to 55%. 75% of the patients had EF more than 50% at 1 year. Pretty remarkable. This is another study published by Dr. Vijayaraman. This was a multi-center study, worldwide study, 8 centers. They attempted left middle branch area pacing in patients with CRT indication and EF less than 50%, more heterogeneous population, and reported 85% success rates. As you can see, the mean age was about 71. They had 44% ischemic cardiomyopathy patients. 40% had about 40% had left middle branch block. Mean follow-up duration was only 6 months, but similar to prior study, you can see with left middle branch area pacing, the mean QRS duration was significantly lower. The NYHA class improved. The EF also improved from mean of 33 to 44% in the entire cohort. Similar findings were noted in patients with underlying left middle branch block when compared to non-left middle branch block patients. So how about long-term performance? This was an important study published by Dr. Wong. This was published in Circ-AE earlier this year. And they attempted left middle branch pacing in 632 patients, reported a strikingly high success rate of 98%. These were the indications, and during a mean follow-up of about 18 months, the pacing parameters were very, very stable. The thresholds were below 0.7 volts at 0.5 milliseconds. The echocardiographic data showed that the EF remained stable despite high pacing burden, and there were no major lead-related complications. This is our intermediate term performance data, which we did an oral presentation last week at HRS. Again, we had 632 patients. We reported a success rate of 91%, 9% failed. Mean age in the overall cohort was 73 years. When compared to successful cases, failed cases were more likely to be men, more likely to have underlying CAD, underlying left middle branch block, and more likely to have wider QRS duration at baseline with cardiomyopathy. Similar to Dr. Wong's study, our results show that during a mean follow-up of 11 months, the lead performance, the thresholds remain low and stable, below 0.88 volts at 0.4 milliseconds. Even the R waves remain stable, as you can see, 15 to 16 millivolts. This was the echocardiographic data. As Shown in the prior study, the EF remained stable during the follow-up, and when we looked specifically at patients who had low EF at baseline, their EF improved during follow-up from mean of 37 to 44. Only 1% of the patients had acute lead dislodgement. Otherwise, there were no major lead-related complications, and none of the patients with left branch area pacing leads had capture threshold more than 2 volts. So why do we see these differences? So it's important to understand the anatomy and histology of the surrounding structures. For His-Bundle pacing, the target zone is narrow, whereas for left bundle branch area pacing, it's a wide landing zone. In addition, the His-Bundle is surrounded by dense fibrous tissue and very less myocardium, resulting in small amplitude R waves and high thresholds at implants. Whereas left bundle branch is surrounded by dense myocardium, resulting in higher amplitude R waves and low thresholds at implant and during follow-up. Potential drawbacks of left bundle branch pacing, we still are trying to figure out criteria to differentiate left ventricular septal pacing versus left bundle branch pacing. These needs to be further validated. We don't know at this point the risk of lead stress fracture and risk of lead extraction. In conclusion, chronic RV pacing is detrimental. Conduction system pacing should be strongly considered in patients with anticipated high RV pacing burden. Randomized control trials are needed for assessing long-term outcomes of conduction system pacing for resynchronization therapy. Although His-Bundle pacing is the ideal physiologic pacing technique, there are challenges at implant and follow-up which may limit widespread adoptability. Left bundle branch area pacing is the best physiologic pacing alternative to His-Bundle pacing. Large randomized control trials are needed for further validation. Thank you very much for your attention.